Hello, my colleagues in new viva session. Surprising session cases, like we agreed last time. Uh, all the cases are in the scope of the exam. Let's start with our candidate number one. Doctor, this is a 30-year-old male patient diagnosed with bacterial meningitis. The patient has lumbar pain and disturbance. Can you ask for control, please? 1 second. Go on.
Yes, I have been presented with axial lumbar MRI for an adult patient with history of bacterial meningitis and low back pain. I will scroll through the last cut and then I will come back to my finding. I'm scrolling. I didn't see any obvious abnormality. I can see that the fecal sac showed peripheral clumping of nerves it is central clumping of nerves at this level, and there is narrowing of the CSF space anterior and posterior to the fecal sac. However, I cannot see any disc bulge, and there is no evidence of mass lesion could be seen within this sequence. Here I can see that there is posterior clumping of the coda equina nerve roots. So in my routine practice, I want also to check the sagittal T2 and the rest of the sequences.
Which sequence do you want?
Sagittal T2 if available.
Sagittal T2. This is sagittal stare. Go on.
Okay, this is a sagittal stare for the same patient. I can see that there is clumping of the coda equina nerves seen at this level. However, I cannot see any obvious mass lesion, and I cannot see any disc prolapse within the intervertebral discs. Here I can see that there is dilatation seen in the terminal part of the spinal cord with a hyper intense signal within this T2 stare.
Where?
It is seen in the film terminali, adjacent to the level of L5 and S1, and showed hyperintense T2 signal. In my routine practice, I also want to see the post-contrast images to see the nature of enhancing of this mass lesion.
Where? Show me by the mouse, please.
Yes, here. If you can see my mouse, I can see that there is abnormal dilatation seen at the level starting from the L5 and ending at S1.
Don't worry about it. What else?
Otherwise, I can see that there is abnormal clumping of the coda equina syndrome. Here is noted.
Don't worry also. Yeah, okay. But what else?
What else? Okay, I can see
And
that.
and and my question, can we diagnose clumping in sagittal?
No, no,
Is
I
this
already saw it. I
hmm,
already saw it within the axial images.
no problem? What else? What
Okay,
else?
I can see that the vertebral bodies showed preserved height and there is normal intervertebral disc. I cannot see any presacral soft tissue mass lesion. And I can see that the neural foramina appears normal on this side. I will check the other side.
Are you
Here
sure,
also,
doctor? Doctor, are you sure?
yes, I can see that the different neural phenomena seen in this level.
What else?
I want to check the posterior elements. I
Concentrate
can
here, please. Concentrate here. What happened?
I cannot see your mouse. If you can click, I can see it. If you click on the image,
Yes.
because I have the control, so I cannot see your mouse. Can we change this sequence to another sequence in order to
There
see
are
the?
very important finding here. Look here, please. Leave the mouse to save the
Ah,
time.
ah.
What is this? What
Here
is this?
I can see that there is multiple areas of hyper T2 intensity,
Yes.
posterior in the at the area of the posterior elements seen between the level
Okay.
4 and 5.
Okay. What is the next sequence do you want?
And next sequence, I want a boss contrast.
1 second, because I think we didn't record, or we record. Okay. Post contrast. Yes. This is the post contrast. Tell
I am
me.
waiting for the images. Okay. Uh, do you want me to scroll?
I will
Okay.
help you. What happened here?
Here I can see that there is enhancing manifested by peripheral enhancing, and the areas within the central spaces shows no enhancing. So I'm thinking about peripheral enhancing mass lesion. This could be due to cystic.
Is this mass?
Sorry.
1 second, 1 second. Could you think the mass will be diffused like this and ill-defined?
No, no, it is like collection,
Yes. So what's your diagnosis?
abscess collection.
Okay. What is the cause of abscess here in this area? Look, nearly here. What is the abscess cause?
Because it could be due to infection. The patient is known case of bacterial meningitis. So this could be due to contiguous infection seen within the the right rectus spiny muscle.
Yeah. From where does this collection originate? What is the
Originates
underlying
from the
source?
spinal cord itself. From the there is maybe fistula formation between the cord and the posterior element.
Yes.
So here I can see that there is connection.
See, doctor, what happened here in this joint, in this facet joint? Could
There is
you?
maybe,
Mm,
yeah, maybe there is a fracture or
no, no. See, there are infected collection here, and
yes,
the facet joint here is looks like what?
it's like a fracture or it's like degenerative changes or
No, no,
dislocated.
no. See, again, peripherally enhanced collection, and facet joint here looks like bright in state and show some enhancement. Did you hear
Okay.
about facet arthritis before? Look,
Yes,
compare. I advise all of you many times before. Compare right with left. If you compare this facet joint with this, there are some fluid here at least. And
yes.
here, here, see? Sorry. So this is facet arthritis complicated by abscess formation. Why? This is, see, 6 months after, this is the normal appearance. Look, the
There is
facet
no
joint here.
connection. Yes.
Yeah, on both sides. Here, just residual. So what is the answer here? Facet arthritis complicated by this abscess, paraspinal and epidural. Okay? Look here, where is the collection here? Collection, this one, epidural, from here. Okay? And this is the facet, this is the center, extended outward in the right spinal rector muscle and the intraspinal extension. So the center, where is the center? This one, facet arthritis, septic arthritis. Very important case, by the way, my colleague. Why? Because one of the life-saving. Why? Because not life-saving, it will cause this, but very important case. Because the patient here supposed to be meningitis, okay? Because he has some symptoms of meningitis, but Actually, he has the origin of the infection of a spinal cord infection or lumbar spine infection is the facet joint itself. So it needs drainage. I think he makes some drainage. No, he takes some antibiotic. Okay. Why? Because this is no maturation of the abscess. What is the maturation of the abscess? It is almost soft tissue. Look here. You can consider all of this as granulation tissue with some cystic changes inside. Overall, we call this one as infective collection or early abscess formation. This is not drainageable. Drainageable abscess must be like a cavity, peripherally enhanced and with considerable amount of fluid. So this patient take antibiotic and he recover well. The most important here to talk about the intraspinal extension here and the center. You mentioned many times clumping, clumping, clumping. Okay. Okay, phlegmon. Okay. Okay, somebody told us this phlegmon. Okay, no problem. Phlegmon or the phlegmon is consisted of granulation tissue. But here, what happened? This is not true, not true amalgamation or clumping of the podoequine nerve root. Why? Because it is mainly compressed by this tissue. It is compressed by this tissue. Radiology, my colleagues, is like a puzzle. We didn't look at one slice and give a diagnosis, and to another slice and give another diagnosis. Okay? Despite yeah, see the nerve root is still scattered, doctor. Still scattered. Still scattered. See? Maybe some clumping, but this is not, see? Nerve root is still scattered. But the main pathology here is the septic arthritis and epidural abscess and infected collection in the paraspinal muscles. This is the main pathology. He called it epidural abscess. And septic arthritis, beside, he didn't talk about this paraspinal infection. Thank you, doctor, so much. Next candidate. Any question in the last case, my colleagues? Phlegmon, okay, but it is not pure phlegmon because it contain many cystic areas, so it is early or evolving abscess formation. Okay, my colleague. Why this abscess not go for interventional radiology? Because it is so small. Thank you so much. Next candidate.
Yes, good evening, doctor.
Good evening. Request control, please.
Yes.
Sorry.
Okay.
90-year-old female patient complaining of vomiting. Go on.
Yes, I'm going on. I'm being presented with MRI scan of an 90-year-old female patient who presented with collapse. I'll scroll through the first presented T2 sequences to check for any salient abnormality.
Yes.
I'll scroll from top to bottom
Okay.
just to check all the series, then give my first comments.
Mm.
The salient abnormality is the presence of left occipital horn hypointense lesion, dark hypointense, much very dark signal compared to the rest of the ventricle, and I can see there is fluid or some dark signal also in the posterior part of the like occipital horn on both sides of this both ventricles. The rest of the brain shows age-related atrophic changes and the chronic quiet matter ischemic changes. In my routine practice, I should review this lesion on different pulse sequences, particularly T1 and any available diffusion or susceptibility weighted images. And also, I can request post contrast images based on the initial assessment.
No post contrast. What else?
We can look for gradient or susceptibility weighted image and also T1 weighted images.
Go on.
Yes, now I have been presented with SWI axial weighted images. There is like marked hypointense signal in the same lesion, which could represent the what's known blooming artifact. That means there is a blood product within this lesion, and also similar signal intensity is noted within the occipital horn of both lateral occipital horn of both lateral ventricles.
What does it
Uh,
mean?
this means there could be hemosiderin content from different blood products. Means this lesion contains a highly vascular lesion. My differential diagnosis, I think, in such case, could be a vascular malformation with bleed within the lateral ventricle, causing this fluid level appearance. Also, other differential diagnosis could include broad plexus
How could
carcinoma,
you
but
how could you
yes,
differentiate? How could you differentiate?
between
Your
between
differential
what? Between
between the different enumerated differential diagnosis now for this left ventricle.
if I'm dealing with cavernous vascular malformation or cavernoma, I think we should do post-contrast study to assess any feeding artery or draining vein, and either by maybe MRI or CT or even conventional digital subtraction angiography. And for the choroid plexus lesions, I think there should be some element of enhancement, but it's likely diagnosis in such a case concerning the age of this patient, which
Doctor, do
is
you want
very
to
old.
ask about something to differentiate?
Between the cavernoma and yes, I would like ask of uh, any clinical relevant history of or prior imaging, if available, any history of hypertension or another thing, which may also could lead to bleeding within the ventricle.
Which prior imaging?
Usually CT.
Okay, look first at this one, and we will go later on
Okay.
to the prior imaging. Please examine
Yes.
this image well, please.
Okay. Um, I'm scrolling through the image again, uh, trying to detect any clues that made uh, um, I'm trying to get any like feeding artery or draining vein in such case, but it's a little bit difficult for me on this images. There is also similar changes noted, I think, within the basal ganglia. And and also maybe here in the
What does it mean?
uh,
Okay.
also another differential, if this patient not hypertensive may have another cause of bleeding, maybe amyloid angiopathy, as if the patient is not hypertensive, but I think it's more cortically located. And also we can see basal ganglia, but you have to have multiple blooming artifacts, which is not too much obvious in this case,
Okay.
like in the
What does it mean? Leave the mouse. What
Time
does
up.
it mean? Listen.
yes,
Okay, thank you.
thank you.
Thank you, doctor.
uh, yes.
If I give you this CT, so what's your diagnosis?
I think this is non-contrast axial CT image. It could
Yes,
be
you because you.
intraventricular bleed,
Yeah. Okay.
intraventricular bleed. Maybe it's
Thank
just
you.
due to hypertension.
Thank you, doctor, so much. What happened here, my colleague? I give him a typical sequence for this intraventricular hemorrhage. By the way, it is a intraventricular hemorrhage due to cerebral amyloid disease. What happened here? Dark T2. So it's really confusing. It may be due to many causes. Okay. Then he asked for susceptibility. Okay. Then what is this? I want first to finish the MRI. What is this? This is dark blooming artifact smearing the cortical sulci here and here. And if you go down, see some of the folia, folia. So this is sidrosis. Okay, sidrosis means chronic bleeding, chronic repetitive bleeding. Next, our colleague should ask me, doctor, I want to ask about any previous city. Why? If he ask about city, he will very, very easily answer it. This is intraventricular hemorrhage. Okay. I know that there are many uh, picture or appearance of amyloid angiopathy. The most common one, which is dark microbleeding in the white gray matter junction here. Okay, but there are many other types, like when you have a lobar hemorrhage, like here due to rupture of one of the main vessels or lobar vessels. Another one, this type of sidrosis because of microbleeding, repetitive microbleeding. And this one, I think also this intraventricular bleeding due to rupture of one of the vessels here. What is the final diagnosis? The most important to at least at least give a proper diagnosis about this intraventricular. And besides that, to search for another pathology. Don't satisfy of your search because there are cirrhosis. Cirrhosis, by the way, very important. Why? Can cause ataxia. It can cause some cranial nerve palsy. So it is an important diagnosis. Intraventricular hemorrhage with cerebral amyloid angiopathy. And according to the cirrhosis, see my colleagues, this is the cirrhosis. This, okay? This also. Thank you, doctor, so much. Next candidate.
Good evening, sir. Candidate 3 here.
Yeah. Hello.
Hello. Good.
Yes.
Yeah, good evening, sir. Candidate 3 here.
Good evening, doctor. Request control, please.
Yeah, yes, sir. Done, sir.
One question before we start in this case. One colleague asked, can epidural abscess be a cause of passage joint infection and phlegmon? Epidural abscess, maybe, but biologic, the infection will start in the joint, septic arthritis, and then it will extend intraspinal, and it will extend paraspinal. This is the logic. Okay, this is the logic, and this is, by the way, the most common. Leave the mouse, please, doctor. Doctor, this patient has abdominal pain. Go on.
Okay. Thank you, sir. Provided with CT scan of the abdomen, these are the plain images in Excel cuts. I will just scroll from top to bottom and to take a minute to scroll through the whole set of images. Okay. Looking at the liver, now just taking liver. Okay. Yeah. Now, so it's jumping, I can see. Yeah. In the first scroll, I could notice there are some soft tissue density areas. So it's lagging. Soft tissue areas are noted along the peritoneum on right side. Just go there. Yeah. Uh, Especially along the anterior-abdominal, right anterior-abdominal peritoneal lining, there are soft tissue homogeneous areas, multiple. I am looking for any other deposits in the mesentery. Sir, can you very much long? I'm looking for lymph nodes and other masses in the peritoneum. Uh, so, uh, yeah, here also, just, yeah. In the adrenal left side adrenal region also I can see a large lobulated mass which is on the bilateral bilateral adrenal sources. It's not staying, sir.
Yes.
Can you? It's very jumping, sir. Yeah. There are
There's
bilateral
a
adrenal region also soft tissue density lesions. Yeah.
yes.
So uh, going down, looking at the for other structures, the bowel is unremarkable with the normal. So it's so the gross finding I can see bilateral adrenal masses with right-sided peritoneal deposits. I am concerned about malignancy. I would like to see the contrast enhanced phases for this case.
This is a contrast enhancer.
Yeah. Okay. So in contrast, I notice. Okay. Just, I think again I have to request. No. Okay. So yeah, now it's working. Sorry. So yeah, again, I'm scrolling from the whole stack of image. I noticed that the adrenal area is so lobulated, relatively non-enhancing masses, and they are replaced by non-enhancing hypodense masses, and also now coming to the peritoneal, this peritoneal. So the soft tissues along the peritoneum are showing significant enhancement and they are lobulated. There is no foci of calcification within them. I think some are collapsed. Uh, no, they appear to be. They appear to be the collapsed bowel. So apart from that, I am just having looking at the other organ. So the liver is. I don't see any focal lesion in the liver. I'm looking at the
Doctor,
kidneys appear. Yeah,
please one second. You diagnose
yeah,
or you pick up some
mm,
finding. Please
mm,
concentrate on it.
mm. Yeah,
Please
yes.
concentrate on the suprarenal,
Mm,
please.
mm. Yeah. These bilateral suprarenal masses are homogeneous and low density. In my routine practice, I will measure the HU of these masses, and if they are less than 10, then I will consider it to be adenomas. Otherwise, in this case, it appears to be more
Do
than 10.
you
I will
think,
the possibility.
doctor,
Mm,
do you think adenoma will not show
Uh,
any
uh,
type of contrast here? Even you didn't tell me, doctor, it
mm,
is show
mm,
contrast or weak contrast or moderate. Do you think
mm.
adenomas will be like this?
Eh, no, no, sir. Um, it doesn't show significant contrast enhancement on post contrast. And they are bilateral. So
Time
this
up.
this could represent adrenal. I want to see that some areas so are low attenuating in could be the fat containing lesions. So this could
No
represent
fat,
an
no fat, doctor, one second, no fat was in it.
Mhm.
Look here,
Okay.
what happened
Yeah.
here?
Yeah.
Look here.
Mm.
This is the delayed. What happened?
Okay. Um,
What happened?
they are they did no fatty areas and they are minimally enhancing. So they don't show significant enhancement. In my routine practice, I'll measure if it is more than 15 or 20 HU of enhancement, but they don't appear to be so more significant enhancement. Uh, and they are lobulated, well defined with no significant stranding. So I consider this could be benign. The other possibilities of even metastasis.
Doctor, one second. Where is the enhancement here? Where?
Uh, Very peripheral, sir. Only thin rim of peripheral enhancement is there.
Okay.
And
Bilateral.
some septa, some
Very faint.
bilateral, yes,
See,
bilateral, very
bilateral.
faint. So,
Peripheral
yes.
enhancing. What does it mean? Adenoma? Did you
The
see any adenoma like this
uh,
before?
uh, no, sir. This could be because of some doesn't clear look like a cyst also, sir. Or
I will help
adrenal.
you. I will help you.
Mhm.
You saw a
Uh,
non-enhancing lesion,
mm,
and in the delayed
mm,
bilateral, nearly symmetrical
mm,
peripheral enhancement.
mm.
What does it mean for you?
Yes. This could be some granulomatous, but they are not also
No,
deposit from any systemic process because of the bilaterality.
no. What is?
Um, they don't appear to be truly cyst-like with a thin peripheral enhancement. So cysts are also
When you see
they don't they.
the same appearance of the kidney,
Mm.
what is your diagnosis?
Sim-
Just peripheral enhancement.
cyst, simple cyst.
No, this is not a
Mm.
cystic attenuation here. This is
Mhm.
solid. So,
That's the same. Uh,
mm,
it could be unlikely to be abscess or impulse because they also will show significant enhancement. So, and there is no fat standing also
okay.
adjacent to the lesion. There is no.
When you see the same appearance,
Mm,
non-enhancement of the kidney and
mm,
the just peripheral enhancement in the
mm.
delay,
Okay.
what is your
One could
diagnosis?
be one could be due to one could be due to infection. Other is a vascular problem like infarction.
Infarction. Thank you, doctor, so much.
Mm,
It is a
Yeah.
bilateral adrenal infarction. Why? It is a
Okay.
very atypical case, I know. But
Mhm.
we should make a brain analysis for what we are reporting. Non-enhancing,
Mhm.
totally non-enhancing, and in the delayed,
Mhm.
just enhancement, peripheral enhancement.
Mhm.
Give like a
Mhm.
differential
Mhm.
diagnosis. Doctor, it is
Mhm.
hypovascularity of the both adrenal. Okay, acceptable. Or it is
Mhm.
infarction. Okay, very nice. Okay, my colleagues, thank you, doctor, so much.
Mhm. Yeah.
The
Yeah.
answer
Thank you,
is
sir.
why it is enlarged? Because the infarction cause cytotoxic edema and the swelling.
Mhm.
Okay, thank you so much.
Okay.
Next candidate.
Yeah. Thank you, sir. Thank you, sir.
Welcome. Next candidate.
Assalamu alaikum, sir.
Salam, request control, please. This patient presented with pelvic pain. Go on.
Okay, these are the axial T2 weighted images of the pelvis in
Yes.
which appreciate heterogeneous echogenicity masses which are centrally hyper intense and peripherally hypo intense, giving a striated appearance. These are very well defined, and the largest lesion is also extending into the abdomen, and another lesion is seen in the lower pelvis, which is apparently heterogeneous in appearance and predominantly hypo-intense. I am looking at the origin of these masses. So it's not scrolling. Uh, these are well separable from the uterus. However, both ovaries are not separately visualized. So it's not scrolling. Sorry. I want to see the I want to see the sagittal images to further confirm the origin of these masses. Okay, these are again solid heterogeneous attenuation masses.
Yes.
These are located in the posterior cul-de-sac.
Okay.
These are but the lowest mass is abutting the uterine surface, and I am looking and at some point there is connection of the superior mass with also with the uterine fundus. Sir, any other post contrast images available?
Uh, this is the contrast. Okay.
On the post-contrast images, these shows a marked post-contrast enhancement without any areas of necrosis.
Mm.
So keeping in view the large solid masses, and these are abutting the uterus, I am
Mm.
concerning for the subserosal uterine fibroids with the myxoid degeneration in the largest lesion, which is extending up to the level of L5 vertebral body.
So what's your differential?
So these are the subserosal fibroids with myxoid degeneration.
What else? Look again, doctor. See, look again. What happened here and what happened here? Okay. Before giving a definite diagnosis, see the relation of these masses to the ovaries and to the uterus. Okay.
Yes, sir. These are seems to ovaries are not separately visualized from both of these masses.
Okay. So what do you think?
So, if they are the other one possibility is the subserosal uterine fibroids, but I can't see any definite connection. It is only abutting the uterine surfaces. The other possibility is the bilateral ovarian solid tumors.
Yes. Okay. Why? What is the underlying cause? When you see both ovaries like this, of huge size like this, what does it
Sir,
mean for you?
most likely it can be due to the Krukenberg tumors from some any other primary, which can be the stomach and breast.
Okay. What else? Look here. What else? Very enlarged ovaries. And what else?
Sir, another possibility is the ovarian torsion, but it is very unusual bilateral ovarian torsion.
So what's your final diagnosis?
Sir, it's likely a bilateral ovarian neoplastic lesions.
Thank you, doctor, so
Time's
much
up.
because time up. Yeah, thank you. See what happened here, my colleague. This is MRI pelvis, and you are presented with very large, huge mass lesion. The first question, the two mass lesion are not totally typical, not totally atypical, typical, sorry. And second point, if you have a deep block here, this mass at least has a peripheral small cysts, okay? Peripheral small cysts. This mass abutting the uterus and inseparable from it. So, subserous fibroid is a possibility. What else? Bring the axial. Where is the ovaries? How to pick up the ovaries, my colleagues? Follow the iliac vessels. This follows the iliac vessels. If you have a deep lock here, there are a pedicle that extend to this mass. And this pedicle is twisted. Look, at least
Yes.
not a good pedicle. Not a good pedicle. And besides that, there are severe central bright too. See, severe. Okay. And especially this mass almost separable from the uterus, almost. Second mass, which is so similar except of the central edema, see, extended to the expected site of the ovary without twisting of its pedicle. See, I think this is the pedicle. I give you the contrast. What is this, doctor? What is this?
Sir, this doesn't shows enhancement. However, the second lesion shows enhancement.
What does it mean for you?
It means the highest lesion is completely necrotic.
Necrotic blood. See the pedicle. This is the pedicle. Follow it. It is like wireless,
Swirling
wireless
sign, yes.
yeah, swirling sign or whirlpool sign. Okay, twisted pedicle. So what's your diagnosis about this one?
It's an ovarian torsion, complete ovarian torsion.
Excellent. What's your diagnosis about the very large bilateral ovary like this? At least ask the examiner, doctor, is this patient has any history of tumor? At least, yes. If the examiner tell you yes, so this is Korkenberg tumor, or at least you can mention it, doctor. Huge ovaries may be due to Korkenberg disease. Okay, doctor.
Yes, sir.
Okay, this is, I think, all the image before. I think, see, all the image.
السلام عليكم.
Mm. Wassalam.
ماشي أحسن في بطني.
Mute yourself, my colleagues. Mute yourself. Next candidate, be ready. So, what is the answer here, my colleague? Unilateral ovarian torsion in Korkenberg. Korkenberg disease means transcelomic metastasis to both ovaries, not the opposite. As I know, not the opposite. Korkenberg disease means transformation of metastasis to both ovaries, transperitoneal. Okay, my colleagues,
Yes, sir.
thank
Thank
you
you.
so much. Next candidate,
Yes, sir.
4-year-old female presented with fever and the right flank pain. Go on.
This is ultrasound kidney of a female patient with right flank pain. The kidney is normal in size and normal shape. There is preserved corticomedullary demarcation. However, the renal parenchyma appears very hypoechoic, likely representing edematous change. These changes are more so at the lower pole. I will further review it on color Doppler imaging.
Yes, this is the color imaging.
On color Doppler, there is no increased vascularity seen. So,
Wait. 1
in
second, 1 second. Again, please. What
yes,
happened here?
on color Doppler imaging, there is no increased vascularity.
There is no increase or there is no vascularity.
There is no vascularity.
Yeah. Okay. So,
So, in altered renal parenchymal echogicity appearing very hypoechoic with absent color Doppler imaging, I am concerned about renal infarction. I'll urgently advise CT. I will correlate with RFTs, and if the renal parenchymal function allows, then I will proceed with urgent CT abdomen pelvis with contrast to look for the cause of infarction, which can include arterial or venous thrombus.
yes. So, what is your
Uh,
next step?
Urgent CT abdomen pelvis with contrast to look at the vascular structures. And I'll urgently inform the clinical physician. If confirmed, the patient will need urgent start of anticoagulation therapy.
Yes. But what is your next step now?
CT abdomen pelvis with contrast.
Yeah. Okay. Scroll,
Okay.
please.
Yes, sir. Sir, I've requested control. Okay. This is CT abdomen pelvis with contrast axial images.
Hmm.
I'll first scroll through the series. Okay, going back to the site of abnormality, I can appreciate that the right renal kidney is completely replaced by a large hypodense area. It is predominantly of low attenuation with peripheral uh, enhancement. The changes are extending into the right chest wall muscles and inferiorly extending along the right side of right abdominal wall till the iliac fossa. And also extends into the posterior back muscles in the pelvic region as well.
So
The
what's your
inferior most.
diagnosis? What's your diagnosis?
I can also appreciate that there are internal hyper dense areas uh, superiorly in this region. So I'm suspecting that there may be underlying renal lesion which has resulted in hemorrhage. I'll further confirm it on venous and delayed phases to see the pooling of blood to confirm
Again,
if there is
see, this
any
is, see, one second. This is the venous phase. What happened here? What happened?
there is large hyperdense collection with internal suspicion of internal active hemorrhage.
Yes, this is around the egg. So one second. There are large collection about perinephric collection. This one, peripheral enhanced. What does see my colleagues? I advise you many times when you uh, describe something, try to signify it. What is it signifying? What does it mean? This collection, what does it mean?
Time
Uh,
up.
Okay. Take 1 minute extra, doctor. What does it mean, this collection, doctor?
so peripheral enhancement, it could be infective.
Excellent. After that, go to the kidney itself. Where is the kidney? This is
Mm,
you are describing this is hemorrhage. This is no. This is the
okay.
kidney, non-enhanced
Okay.
kidney, and this is some central enhancement. So, what does it mean for you? Non-enhanced kidney.
Completely infarcted right kidney.
Excellent. Could you rearrange what just you said now? Infected collection around infarcted kidney. Could you
Okay.
give me a definite, proper logic diagnosis? What is the sequence? The infarction is the first event, or the infection is the first event? What happened first?
Mm, sir, I think infection has occurred first.
So
Uh,
after that, what happened?
infection could infection post infection there might have been vascular thrombus which has led
Venous
to
infarction.
complete infection.
Venous
Yeah.
infarction. That is happened. That is exactly what happened. What happened here? This is the kidney completely infarcted. But before that, there are large perinephric abscess or collection. See,
Yes.
bending down along the down to the right iliac fossa down. Okay, so
Okay.
the chronological sequence is infection, pyelonephritis. Okay, all of this is the paracolic gutter, by the way. All of these are a retroperitoneal process because the kidney is retroperitoneal. Okay,
Yeah.
so what
Yeah.
is
All right.
our answer here? Pyelonephritis, complicated first by abscess and and by thrombosis. Whatever the artery thrombosed, this is arterial, sure, not venous, sorry. Why? Because the venous, this is the venous phase. There are some venous enhancement. But if you follow the renal artery, this is the level of renal artery. Nearly the, see this one. This is the origin of the artery. And here, I think no enhancement. This is from the vein. This is the renal vein. So our final diagnosis, this is post-infective renal infarction. This is for urgent resection. Thank you, doctor, so much.
Sure,
Uh,
sir.
before we take the last candidate, my colleagues, my advice to all of you, number one, to signify what you are saying to the examiner. Number two, try to build a chronological sequence and scenario and diagnosis when you are speaking. You're not just speaking with the examiner, you are in the same time make a deep analysis in your brain. Because I will give you example in mine. When I was in the Viva, I start with describing this one, okay? And this one, after that, each photo, each image give you another information about what could be the case. And after that, from the ultrasound, our colleague pick up it may be kidney ischemia. This is great. From the CT, there are infection. So combine both entity. Combined, please. Both entity equals infection plus infarction. You should ask yourself which one is the first, infection then infarction. Okay? Then go to the kidney. Number one is completely ischemic. So it is almost arterial. Number two, if you look here, this is the IVC. This is the renal vein. This is the aorta. Most of the renal artery is not visualized. So this is arterial ischemia. Thank you so much. Last case. Last candidate. Hello? Hello?
Do we have candidate number 6?
Yes, 1 second. Sorry. Can you hear me?
Yes?
Sorry, my screen is not working. 1 second. Let me, if you can just give me 1 minute. Okay. Yeah. So let me ask for remote.
I will scroll for you. Doctor, this patient has recurrent episodes of headache. Okay? Go on for a long time. He is young patient, by the way. Go on.
Okay. So I'm sorry, I'm scrolling or you are scrolling?
You are scrolling.
Okay. So I'll just scroll through the images and then I'll describe my findings. These are the axial flare images of the patient who has presented with, sorry, okay, I can see that in focal area of abnormality, which is present in the right uh, rectal region, which is showing internal area of hypointensity with peripheral high intensity signal on flare. I don't see any ventriculomegaly. Midline shift is seen and no other focal mass seen on rest of the images. And coming back to this lesion, in my routine practice, I would like to compare with previous, other images like T2 or DWI to take it
Where is the
further.
lesion, doctor? Doctor, where is the lesion?
The lesion is present in the right, I think, centrum semiovare region on the right side.
What else? This only one?
And I think there are, okay, let's just have a quick look. If I could find, there is another subtle hyper-intense focus, tiny one on the left side as well, this
Mm-hmm.
one. And otherwise, I don't see any other lesion. Yeah. Can you have a look on other
So how many lesions, doctor,
sequences?
do you find?
So I think these are two lesions. The larger one is in the right side central semiovale, and the left, and we could find
What does it
probably,
mean for you? What does it mean for you, doctor?
and it is. I think there are further lesions as well. I could see there's in the right side as well. So these are sort of uh, hyperintense with internal hypointense signal and linear configuration. I'm suspecting if this could be due to underlying watershed infarct. That could be a possibility in this configuration. I
What
would
else?
like to know correlate. Sorry, and other I uh, like I okay. The other possibility would be any metastasis, but that is less likely with this configuration, which is more linear. And so I would like to correlate with the clinical presentation. If it is acute, then I would consider first option. And to take it further, I would like to have uh, DWI or correlate with other images.
What image do you want?
Do we have DWI images?
This DWI.
Okay. So DWI images are not showing diffusion restriction. Okay, so I think it's not an infarct. So I would like to have a look on then other post-contrast images to see if we have any enhancement in these lesions.
What else?
Because these are not showing any mass spec, and these are multiple
In the mouth.
lesions. And
Have a look here, doctor, please.
okay, so T2 images. Sorry, I'm just scrolling. Right. So on T2 images, these lesions which I saw in the right centrum semiovale is basically not identifiable, and it's not showing any. Basically, it is faintly visualized, I would say, and I think it's a case of T2 flare mismatch. So, and it's not showing any enhancement. Can we see post contrast to see if it is showing any enhancement or not?
No post contrast.
So
Look, doctor, see, you see multiple because more than one lesion, consider almost multiple. Bright T2 or flare signal of the white matter. And then I give you this one. These concentrate.
Time up.
Concentrate here. Okay, thank you. Give us 1 minute, please.
mhm,
When we are presented with, in the beginning, I told you this is a young patient. Young patient. See,
mhm,
and you find one frontal here in the corona radiata, not the central semoval. Almost, this is corona radiata. Corona radiata is the white matter just above the lateral ventricle. Okay.
mhm.
Central semoval is more hyacinthine. Okay, and another one here, another one more posterior here, parietal.
Yeah.
Okay,
Mhm,
Another one here. When the patient is young age, 9 years. Young age means young age, whatever. He is not elder. So I'm not
Okay,
talking
so
about.
could it be Moya Moya?
Yeah, خلاص, give me my chance. Young age means that
Yeah.
I'm telling you from the beginning,
Mm,
exclude atherosclerotic changes or thrombotic and
yeah.
like this. So, and
Right.
you
Yeah.
find this multiple white matter, multiple
Yes.
non whatever, it is non-territorial, sure, but multiple
Mm-hmm.
bright T2, you go immediately to the DWI.
Yeah.
I'd like to advise you, DWI will give you, is this acute or subacute or chronic?
Mm-hmm.
Okay. But after DWI, you told me this is not infarction. No, this is not correct answer. What happened? This is very old infarctions.
Oh,
Multiple
then thoughts.
in young
Okay.
age,
Yeah.
yeah. In young
Mm-hmm.
age, multiple infarction. Number one means vascularity. Number two, why you include metastasis here? As I remember, I think you talk
Yeah.
about metastasis. No, metastasis should have considerable amount of edema and any
Edema.
type
There
of
is no
mass
edema.
effect. And I told you from the beginning, this is young patient. Sure, he may have a metastasis. I'm not totally disagree with you. Number three, I give you, I give you something, and I concentrate. I told you many times, concentrate. One of the very commonly missed review area is
Mm.
the vessels. Look here. At least you can't see the MCA in both sides. You just see
Yeah. Distal and
tributaries,
the. Mm.
collaterals. Okay? See here.
Mm-hmm.
This is very obvious here, especially this one. This one. Don't expect that the examiner will give you moya moya like this one. This is when we are
Mm.
studying. Don't expect.
Yes, exactly.
Or he will give you
Mm-hmm.
this one. In Viva, they like too much to give you Excel. And as I remember, they didn't even talk about other plans except very few occasions. I'm talking about my personal experience. Okay. Also,
So
don't
bilateral
expect.
MCA are showing, yeah, I see a
Yeah, this is a
bilateral
puff
MCA.
puff of smoking,
Puff
whatever.
puff of smoke with collateral
Yeah,
and yeah.
collaterals. So my advice for all of you, my colleagues, Excel is very critical and review areas and listen well to the examiner. This is a moya moya disease. Moya moya disease when the case when there are no underlying cause. Idiopathic moya
Okay.
moya syndrome. It means there are underlying cause like neurofibromatosis. Don't expect
Mm-hmm.
this one. Don't expect this one. When you studying, always be familiar with the axial because this is the original radiology. So it
Exactly.
is a moya moya disease in a patient of 9-year-old female patient. Why I didn't
Mm-hmm.
give you the exact age? Because that is exactly happening in the exam. If I
Mm-hmm.
told you from the beginning, this is a 9-year-old, patient, exactly you will suspect. If this 20 years old patient and you find this one, two, three, multiple white matter,
Mm-hmm.
ischemic, like change, not changes, foci, you must think about vasculitis. Vasculitis,
Vasculitis, yes.
yeah, vasculitis. Somebody will ask me, does moya moya should be included in the vasculitis? No, it's another entity. It is totally different, and it affected very young age group. But I'm talking about vasculitis. I mean the vasculitis, by especially the patient. I think I presented with one case in my postgraduate in Egypt, 20 years
Mm-hmm.
old, and it was like this. But only the difference was the age. I told the examiner
Age. Okay.
immediately
Okay.
it is vasculitis. He asked me what is the most common cause. She is female, systemic lupus. The case,
SLE.
I finished the
Mm-hmm.
case immediately, or he removed the case immediately. Okay, my colleagues?
Thank you, Dr. Rami. Thank
Welcome.
you.
Anyone has any
Nice
question? Welcome. Any question, my colleagues? Thank
Yes, I have a
you.
question.
Yes.
What is the difference between Moya-Moya syndrome and phenomena?
I just answered the difference between Moya-Moya disease and Moya-Moya syndrome. Moya-Moya disease means there are no underlying cause, idiopathic. Okay. Moya-Moya syndrome means there are underlying cause. Okay, underlying cause like what? Like all these causes. About 20, 30 causes. Fibromuscular dysplasia, radiation, sickle cell, systemic loop, whatever. But I don't know what is Moya-Moya phenomena. Do you mean by that Moya-Moya syndrome?
Syndrome, yes.
Yeah, I know syndrome and Moya-Moya syndrome and Moya-Moya disease, but I didn't listen before about Moya-Moya phenomena. Thank you so much, my colleague. Thank you, Dr. Ali, so much.
Thank you, sir.
Bye-bye.